Good evening, everyone. I'm audible and visible, guys. Please tell me in the comment section. Good evening, everyone. Okay, thank you. So today we are going to start with the general pathology part 2, guys. I hope everyone have watched the part 1. We have covered cell injury. So have a quick recap what we have studied in the part 1. Let's have a quick recap. So in the part 1, guys, first of all, we studied about a cell injury, what can be the different reasons of the cell injury, and followed by that what can be the outcomes. Then we learned about an adaptations, hypertrophy, hyperplasia, atrophy, metaplasia, and dysplasia. Further, guys, the main part where the question can be expected from the types of necrosis. Okay, so the tombstone necrosis seen in tombstone appearance is in coagulative necrosis, cheese-like appearance in the caseous necrosis, fibrin and fibrinoid type of material deposition is seen in the fibrinoid necrosis. The classical examples of malignant hypertension, rheumatic heart disease, and the polyarthritis nodosa. Then apoptosis, guys. Apoptosis may have studied all the L containing gene as an anti-apoptotic genes and pro-apoptotic genes. So the question that they can be asked, intrinsic and the extrinsic pathway. So what are the caspases for the extrinsic pathway? Caspase 8 and 10. And the executioner for the extrinsic pathway is 3, 6, and 7. While as for an intrinsic pathway or a mitochondrial pathway, we have caspase 9 as an initiator and executioner as caspase 3, 6, 7. Okay. Then further, guys, we studied about a free radical injury as well, necroptosis, pyroptosis, pharoptosis. Okay, so today we are going to start with the pigmentation. Okay, so today we are going to start with the pigmentation, followed by that we'll cover the inflammation, acute and chronic. Okay, so let's begin, guys, without any further delay. So last time, the last topic that we have studied was the free radical injury. Okay, now when these reactive oxygen species when these reactive oxygen species, guys, they react with the fatty acids, there is a generation of a lipid peroxidase, okay. And also, guys, there is an accumulation of the pigments, or intracellular accumulations, so the first intracellular accumulation or the first pigment that we are going to study is the lipofuscin. The first pigment that we are going to study is the lipofuscin. Now what is this lipofuscin, guys? It's a yellow brown pigment which is derived from the lipid peroxidation. So yesterday, day before yesterday, when we have studied about the reactive oxygen species, they react with the fatty acids, protein and DNAs. So further they will cause cell death. Okay, now while a reactive oxygen species is reacting with these lipids, there is a generation of a lipid peroxidase. Okay, along with that there is a pigmentation or an accumulation called as lipofuscin. So write down about lipofuscin, guys. It's a yellow brown pigment derived from the lipid peroxidation. It's derived from the lipid peroxidation. Okay, it's also called as wear and tear pigment. Or it's also called as pigment of aging. Okay, it's common in aging cells. This pigment is common in aging cells and it is predominantly seen in the cells of liver and heart. Okay, so the FMG question PYQ was asked that yellowish brown pigment, guys, seen in the heart cells or seen in the cells of a liver, guys, old age person. So what is your answer, guys? Which pigment? Lipofuscin. Okay, so here you can see, guys, yellow brown pigmentation seen in the cells of liver and heart, common in aging, guys, also called as wear and tear pigment, lipofuscin. So write it down, guys. It's common in aging cells. liver and heart. Okay guys, it's also called as perinuclear intralysosomal pigment. It's a perinuclear intralysosomal pigment. Intralysosomal pigment. Intralysosomal pigment. Okay, so the first pigment, guys, which is due to the lipid peroxidation. When a reactive oxygen species react with the lipids, there is a generation of a lipid peroxidase. Okay, there's an accumulation of the pigment, and that pigment is a yellow brown pigment called as wear and tear pigment, lipofuscin. Now the second one, guys, melanin. It's a tyrosine derived pigment. So you already have studied in the biochemistry, guys. Melanin comes from the tyrosine. It's a tyrosine derived pigment. It's a tyrosine derived pigment. Okay, it is a dark brown or black pigment. It's a dark brown or black pigment. Dark brown or black pigment. It's a dark brown or black pigment. It is responsible for the color of skin, hair and eyes. This pigment, it's responsible for the color of skin, hair and eyes. Okay, now if this melanin is absent, what will happen, guys? If the melanin is absent, there is a condition called as albinism. Okay, if the melanin is absent, what is a condition called as albinism? And what is an enzyme deficient in albinism, guys? Anyone? What is an enzyme deficient in albinism? It's a derma question, guys. What is an enzyme deficient in albinism? It's tyrosinase. Okay, guys, it's tyrosinase. I will write it here, guys, from the dermat. They can ask. Enzyme deficient, it's tyrosinase. Enzyme deficient is tyrosinase. If you want to see the classical picture of albinism, guys, these people are more prone to the malignancies as well. Okay, melanin inhibition, guys, it's onset from the birth, and there is a tyrosinase deficiency and increased chances of the skin cancer. Oculocutaneous disorder. That's why it involves eyes, hair and skin. Is it okay, guys? Chalo, everyone look at the picture, guys, and remember, guys, tyrosinase deficiency. Then further, guys, write it down, guys. It protects against the UV radiation. It also protects against the UV radiation. It protects against UV radiation. It protects against the UV radiation. Okay, and the stain that we use for melanin is called as Masson-Fontana stain. Write it down, guys. The stain for melanin. What is the name of the stain? Masson-Fontana stain. All these stains are very important. Okay, Masson-Fontana stain. Masson-Fontana stain. So all the points about a melanin are clear, guys. It's a tyrosine derived pigment. It's responsible for colors of the skin, hair and eyes. If there is absent melanin, guys, the condition is called as albinism. Oculocutaneous disorder. The enzyme deficient is tyrosinase. Okay, and the stain that we use is Masson-Fontana stain. Okay, you guys can ping me on the Telegram. I'll give you the PDF. Part 1, Part 2 both today. Okay, I'll give you the PDF, no problem. Then, guys, hemocedrin. You already know heme, iron, so it's an iron derived pigment. It's a iron derived pigment. Okay, for now my dear students, you understand. Okay, PDF, don't worry about the PDF, you guys can ping me on the Telegram. Okay, I'll send you the PDF. Okay, so it's a iron derived pigment. Okay, write it down. It's a golden brown pigment which accumulates in the chronic overload, iron overload. Golden brown pigment accumulates in chronic overload. Accumulates in chronic overload, like thalassemia. Which conditions? Thalassemia, multiple blood transfusions, and chronic hemolytic anemia. Chronic hemolytic anemia. Okay, and then guys, the stain that we use for the hemosiderin. Okay, Prussian blue stain. Okay, and the reaction is called as Pearl's reaction. So Pearl's reaction is seen with which pigment, guys? Hemosiderin. Pearl's reaction. So remember guys, Prussian blue stain, hemosiderin, Pearl's reaction, hemosiderin, and it's an iron derived pigment seen in the conditions when there is a chronic iron overload, like thalassemia, multiple blood transfusions, and chronic hemolytic anemia. Okay, remember about thalassemia guys, the index that we use for the thalassemia is called as Mentzer's index. Okay, which differentiates thalassemia with the anemia. And remember, the classical faces that are seen in case of thalassemia are called as chipmunk faces. Okay, are called chipmunk faces. Okay, then further guys, amyloid. What is amyloid? It's the extra proteinaceous deposits. Amyloid is the extra proteinaceous deposits. Now this extra protein is deposited in the multiple organs guys, that you will study in the amyloidosis. Okay, and when this amyloid, what is this amyloid? It gets deposited in the different organs. So accumulation of the misfolded proteins. Accumulation of misfolded proteins. And the stain that we use is Congo red stain. Congo red stain positive, and under the polarized light, okay, this is a hemosiderin guys, iron derived pigment, and under the polarized light it gives a apple green birefringence. Under the polarized microscopy, this amyloid guys, the appearance is apple green birefringence. Apple green birefringence. Okay, again a PYQ was asked guys, image was given, what is this? It is an amyloid deposition. Okay, amyloid deposition under the polarized microscopy guys. It's a apple green birefringence. Okay, then amyloid can be deposited into the tongue, causing the nodules in the tongue, and the patient will have macroglossia. Na? Amyloid deposition can cause a raccoon eyes. Different organs we have the accumulation of the amyloid, that we'll study in the amyloidosis. And then you will remember guys which type of amyloid it is: A beta 2, ATTR, and microglobulin. So that you will discuss in the amyloidosis chapter. Then the anthracosis guys. Now all these pigments are the endogenous pigment. Now what I'm going to talk about is an exogenous pigment, that is from the outside. Okay, anthracosis. So write it down guys. It's the most common exogenous black pigment. It's most common exogenous. It's most common exogenous black pigment. Now if you remember from the PSM, guys, in PSM point of view, when I was talking about a pneumoconiosis, different pneumoconiosis I've taught you that the most common is silicosis, then followed by that we have different types. We have asbestosis, we have bisonosis, we have bagasosis, we have berylliosis, okay, and we have anthracosis. So what is the source of anthracosis, guys? It is due to the coal dust. It is due to the coal dust. So write it down, guys. It accumulates. Now this coal dust, guys, it's an exogenous pigment. This anthracosis, this black pigment, it accumulates in the liver and muscles. It accumulates, sorry, most common exogenous black pigment, sorry, it accumulates in lungs. It accumulates in lungs, okay. And what exactly are there? Carbon particles, okay. It's also common in smokers. It's also common in smokers, okay. Carbon particles, that's why it's all called black lung. क्या बोलते हैं, guys? Black lung. Now one question from the medicine point of view, guys. If there is a rheumatoid arthritis along with the anthracosis, okay, if anthracosis plus rheumatoid arthritis, what is the syndrome? Anyone in the comment section, guys? Rheumatoid arthritis plus anthracosis, it's also called as rheumatopneumoconiosis. The syndrome is called as Kaplan syndrome. What is the name of the syndrome, guys? Kaplan syndrome. And along with that, if your patient is having a splenomegaly, okay, we call it as a which syndrome? Felty syndrome, okay. It's also called as rheumatopneumoconiosis. So rheumatoid arthritis plus anthracosis is Kaplan syndrome. Along with that, if the patient is having a splenomegaly is mentioned, it goes with the Felty syndrome, okay. So the Kaplan syndrome, it's also called as rheumatopneumoconiosis. It's also called as rheumatopneumoconiosis. So anthracosis, guys, what is a source, guys? It's a coal dust, or it's seen in smokers, and it's the most common exogenous from the outside. It's the most common exogenous pigment, okay. Then, guys, glycogen, write it down. Granular pink staining materials. First of all, this glycogen, it accumulates in liver and muscles. Okay. And this glycogen, guys, it is seen increase in which diseases, guys? It's increase in glycogen storage disorder. What is the most common glycogen storage disorder? Tell me in the comment section, guys, from the biochemistry. It's increased in glycogen storage disorder. Most common glycogen storage disorder. Anyone in the comment section, guys? Most common glycogen storage disorder. Anyone? Most common glycogen storage disorder. It's a PYQ as well. Most common glycogen storage disorder. Yes, it's a basic biochemistry question, everyone. Started with the M. No, not that one. Most common glycogen storage disorder. Yes. No, G6PD is not there. All you do is you remember the enzyme deficients. वो तो आसान है, A, B, C, D. Yes, you are right, McArdley's. Okay, McArdley is the most common one. Most of the times you mark von Gerke's, okay. So remember McArdley's Glycogen storage disorder is the most common glycogen storage disorder. Okay, now if we see this, guys, this is a black pigment, guys, anthracotic pigment in anthracosis. Okay, and this one, guys, it's a pass stain positive. Okay, periodic acid shift positive. Which one? Glycogen. And this pinkish material, guys, this pinkish stains, they represent a stored glucose. So write it down, guys. Granular pink staining material represent the stored glucose. Granular pink staining materials represent stored glucose. They will represent stored glucose, and it's pass stain positive. It's pass stain positive. So what is the stain that is used for the glycogen, guys? Pass stain. Okay, pass stain. Amyloid wise Congo reg stain. Homocidrin में Prussian blue stain. Melanin में, guys, Mason Fontana stain. Okay, so remember all these stains, guys. They are very important. One question can be expected from the pigmentation. Okay, either lipofuscin, melanin. In melanin, please remember albinism and the enzyme deficient in the albinism. Okay, hemocidrin, guys, remember that. Amyloid, anthracosis, and glycogen. Okay, now, guys, let's move to the calcifications. We have two types of calcifications. We have dystrophic calcification and we have metastatic calcification. If I talk about dystrophic calcification, it's a calcification seen in D for dystrophic, D for dead or degenerated tissue. D for dead or degenerated tissue. D for dead or degenerated tissue. Okay, serum calcium is normal. Serum calcium is normal. Okay, and it's usually localized. It's usually localized. If I talk about metastatic calcification, guys, it's seen in living tissues. It's seen in living tissues. Okay, the serum calcium levels are high. There is a hypercalcemia. So write it down, guys. Serum calcium is high. Serum calcium is high. You have a patient with hypercalcemia. What will be your management, guys? Let me check your medicine. Patient with hypercalcemia, क्या दोगे? Hypercalcemia में what will be your treatment? Anyone in the comment section? You always answer for hyperkalemia. Now hyperkalemia, you know calcium gluconate. Very nice. Hypokalemia, you know KCl. Now tell me hypercalcemia. You have patient with hypercalcemia. What will be your treatment? Write down in the comment section, guys. Either you know, either you don't know. So write it down. Hypercalcemia treatment. Okay, hypocalcemia, you know. Calcium is less, you give calcium. What you will give in hypercalcemia? Sir, I will take out calcium. No? Tell me the answer. Yes, faster, guys. Yes, we use different drugs. We use first normal saline, we use bisphosphonates, okay? We use calcitonin. So remember that. Chalo. Now, metastatic calcification, guys, the serum calcium is high. So there is hypercalcemia and it's usually diffuse. Yes, we can use that as well. Usually diffuse. It's usually diffuse. Okay, now the association, dystrophic calcification, it is seen in remember, guys, tuberculosis. It's a question important, guys. They will give you the question and you have to answer in which of the following condition there is a dystrophic calcification, or which of the following condition there will be. Yes, prednisolone, magnesium sulfate, all correct. Okay, they will ask in which of the following condition there is a metastatic calcification or a dystrophic calcification. So remember the examples, guys. Tuberculosis, you have rheumatic heart disease, rheumatic heart disease, Jones criteria, Ashkoff body, caterpillar cells, है ना, rheumatic heart disease. Okay, you have atherosclerosis. You have atherosclerosis. All the tumors, guys, have a dead or degenerated tissue. That means dystrophic calcifications. Okay, myocytes ossificans. Okay, myocytes ossificans. So what is this myocytes ossificans? I have discussed yesterday, guys, day before yesterday, when I was discussing about a metaplasia. I told you there is a type of a connective metaplasia. In connective metaplasia, what is happening? The bone is replaced, the muscle is replaced with a bone, and such a condition, after the trauma, such a condition is called as myocytes ossificans. Okay, Monkberg sclerosis is an example. And infections like CMV and schistosomiasis. Schistosomiasis. So remember all these things, guys. We have tuberculosis, we have rheumatic heart disease, atherosclerosis, tumors, myocytes ossificans, Monkberg sclerosis, infections like CMV and schistosomiasis. Okay, if I talk about the association in metastatic calcification, guys, the first one goes to the parathyroid adenoma. Parathyroid adenoma. Okay, we have chronic kidney disease. वहाँ पे इंक्रीज फॉस्फेट होता है तो we have primary hypoparathyroidism. We have primary hypoparathyroidism. We have sarcoidosis. We have Paget's disease. We have Paget's disease. We have multiple myeloma. We have multiple myeloma. Okay, we have Williams syndrome. We have milk alkali syndrome. Okay, so these all have which type of calcification, guys? Metastatic calcification. So remember the associations, guys. Associations are important. So tuberculosis, rheumatic heart disease, atherosclerosis, tumors, myocytes ossificans, Monkberg sclerosis, and infection have a dystrophic calcification. In equation, the examiner will give you a hint that the calcium level is normal. Okay, and metastatic calcification, there is a hypercalcemia. There is hypercalcemia. Okay, the associations, we have parathyroid adenoma, we have chronic kidney disease, we have primary hypoparathyroidism, we have sarcoidosis, we have Paget's disease, we have multiple myeloma, Williams syndrome, and milk alkali syndrome. Okay, so it's about dystrophic calcification and metastatic calcification. Now the calcium stains, guys. The stain, if you have a minimal calcium, okay, if there's a minimal calcium, the stain that we use is alizarin red. Okay, alizarin red. Okay, this is the alizarin red stain for the minimal calcium. Okay, and if we have a, that's what phosphate I mentioned in the CKD, वहाँ पे increase phosphate होता है तो calcium ज़्यादा होता है. Von Casa stain, guys, it's also for the calcium when we have more calcium. Okay, less calcium, alizarin red, and Von Casa stain. Von Casa stain. Okay, the other stains, guys, we have Masson trichome. It is for the collagen, and it gives blue color to the collagen. Gives blue color to collagen. It gives blue color to collagen. Okay, and write it down, guys. It's used to confirm the fibrous tissue or the collagen deposition in the tissue. So which type of stain is used to check the collagen, guys? It's Masson trichome. Okay, Masson Fontana, don't mix it with Masson Fontana, guys. Masson Fontana is for the melanin. Masson Fontana is for the melanin. Okay, so write it down that it's used to confirm the fibrous tissue. It's used to confirm the fibrous tissue or collagen deposition in tissues. Or collagen deposition. Okay, so the stain is called as Masson trichome. Okay, this is a classical stain, Masson trichome. Masson trichome stain. Okay, then guys, we have a stain that is used for nucleic acids. The stain is called as acridine orange. Okay, what's the name of the stain? Acridine orange. So write it down. It's used for nucleic acid like RNA, DNA. Used for nucleic acid. Okay, the stain used for nucleic acid, DNA, RNA. So it started with the name only, guys, acridine orange. Okay, acridine orange. Acridine orange for nucleic acids. Acridine orange for nucleic acids. Then guys, we have toluidine blue. Okay, it is for the detection of mast cells in tissues. Detection of mast cells in tissues. Okay, detection of mast cells in tissue. Simple question was asked, FMG, mast cells secrete what? Histamine. Okay, mast cells secrete histamine, which is a vasodilator. Chalo. Then guys, Gomori methamine silver stain, guys, GMS stain we have discussed in case of an HIV, guys, when there are opportunistic infections in the HIV, when the CD4 count is less than 200, the particular type of pneumonia is occurring called as pneumocystic jirovecii pneumonia. And for that particular condition, guys, what is the name of the stain we have discussed? It's Gomori methamine silver stain. It's Gomori methamine silver stain or Grocot's Gomori methamine silver stain. So write it down, guys. It's used for fungus detection. It's used for fungus detection. Pneumocystic jirovecii के लिए भी use करते हैं. Okay, and what is the prophylactic drug that we use for pneumocystic jirovecii? Tell me in the comment section, guys. What is a drug of choice or prophylactic drug? Both are the same. Okay, you have a patient coming to you with a CD4 count less than 200. Okay, so which of the following opportunistic is there, guys? It is pneumocystic jirovecii. So what will be your prophylactic or the drug of choice? Write down in the comment section. What is a drug of choice? I've already discussed that. Your drug of choice is cotrimoxazole. Your drug of choice is cotrimoxazole. Okay, then last one, guys, the sweet reticulin stain, guys. This is a Gomori methamine silver stain. It's written in there, guys, already. Pneumocystic jirovecii. Okay, CD4 count less than 200. CD4 count less than 200. Okay, and this one, it is toluidine blue. And this toluidine blue was used for detection of the mast cells. It was used for the detection of mast cells. Okay, one question, guys, from the micro. Remember, guys, for reticulocytes, anyone in the comment section, for reticulocytes, what is the name of the stain? Reticulocyte. What is the name of the stain? It's supravital stain. Don't skip a single stain that you know. Supravital stain. Okay, for reticulocyte, supravital stain. This was a PYQ. Okay, so the last one, guys, sweet reticulin stain. It detects the reticulin fibers, collagen 3. It detects reticulin fiber. It detects reticulin fibers. Okay, collagen 3 in liver tissues. That's collagen 3 in liver tissues. Yes, right, supravital. Okay, so this was all about our first chapter, guys, cell injury. Okay, have a quick recap, guys. Let's have a quick recap. So today we started with the pigmentation, guys. First one was the lipofuscin. That is a yellow brown pigment, guys. It's derived from the lipid peroxidation. I exactly told you where exactly it's coming from. When the reactive oxygen species are reacting with the lipids, there is a lipid peroxidase generation, and the pigment is accumulated, called as lipofuscin. It's also called as wear and tear pigment, guys, or the pigment of aging, predominantly seen in the aging cells of liver and heart. Melanin, it's a tyrosine derived pigment, guys, responsible for the color of the skin. If this is absent, the condition is called as albinism, and the enzyme that is deficient in albinism is called as tyrosinase. Further, guys, the hemosiderin, it's an iron derived pigment, guys, seen in the conditions when we have a chronic overload. The stain that we use is Prussian blue stain, and the reaction, Pearl's reaction. The amyloid deposit, it's an extra, when the extra protein are deposited in the organ, guys, amyloid, and the stain that we use is Congo red stain. On the polarized microscopy, guys, it gives appearance called as apple green bifringence. Okay, then anthracosis, guys, it's the most common exogenous pigment seen with the people working in the coal dust industry and the smokers. There is a black carbon particles deposition in the lungs. That's why it's also called as black lung. Okay, and when rheumatoid arthritis plus the pneumoconiosis is there, that we call it as Kaplan syndrome or the rheumatomycoconiosis, and along with the splenomegaly will be there, which is known to be as Felty syndrome. The glycogen, guys, it's accumulated in the glycogen storage disorders. The most common is in McArdle one, and it accumulates in the liver and muscles, है ना? And the stain that we use is PAS stain. Then calcification, guys, dystrophic. Okay, then the dystrophic calcification and metastatic calcification. Dystrophic calcification is a calcification seen in dead or degenerated tissues, guys. The serum calcium level is normal and it's usually the localized. What are the conditions it's associated with? It's associated with tuberculosis, rheumatic heart disease, atherosclerosis, tumors, myocytes ossificans, Monckeberg sclerosis, and infections. While as metastatic calcification, there is a hypercalcemia and it's associated with parathyroid adenoma, chronic kidney disease, sarcoidosis, multiple myeloma, milk alkali syndrome, etc. Okay, then further, guys, remember for the calcium, what is the stain? We have von Casa stain and alizarin red. We have von Casa and alizarin red. One question was given, guys. Okay, and I've recently gone through this question. The question was given, and Samoma bodies was the picture given, and it was mentioned that which of the following stain will be used for the given image. Okay, and you already know Samoma bodies are the calcium bodies, okay, which are centered in the center, है ना? Calcium bodies centered in a center, seen in the conditions like papillary thyroid carcinoma, ovarian tumor, meningioma, mesothelioma. All these conditions are what, guys? Samoma bodies. Okay, and what is the stain that we use for Samoma bodies? They are calcium rich body they are calcium rich pathological bodies, guys. So the stain, the answer will go to the von Casa stain. So they can ask the integrated question. You all know Samoma bodies, you all know where exactly Samoma bodies is formed, but remember this, there is a calcium in the Samoma bodies, and the stain that we use for Samoma bodies, the answer goes to the von Casa stain. Okay, integrated question aa sakta hai. The other stains, guys, Masson trichome for the collagen, acridine for the nucleic acids, toluidine for the mast cells, gomorimethambine for the fungal infections, and last one for sweet reticulin for the reticulin fibers, collagen 3. So this was all about the chapter cell injury. Now let's discuss inflammation. Is it clear, guys? All cell injury is clear? Everyone, just write me in the comment section, guys. We start with the inflammation. Let me know in the comment section, guys, all of you who are watching. Okay. Understand, guys, general path 3, 4, 5 questions will come. Okay, so you have to be active, interactive, and answer the questions. Chalo, inflammation. Okay, what is inflammation, guys? It's a response to the vascularized connective tissue injury. Okay, it's a response of the vascularized connective tissue to the injury. So whenever the injury is happening, the response to that vascular injury, is called as inflammation. Okay, Simple. Now guys, types of inflammation. So before starting every topic guys, basic चीजें पढ़नी पड़ती है ना. It's important to read out those basic things. Why? Because basics are the one which will make the base of a concept. Okay, you might will feel okay, acute, chronic, you already know, but later on when we step deep into the concept, these basic things are what we need. Okay, in beginning you will feel like okay, acute means all of a sudden, chronic means when acute is for prolonged time, है ना. So but to understand the full concept, basics is very important. So understand types of inflammation. Now we have two types of inflammation. One is acute, another is chronic. Okay, by the name only guys, the onset, acute means when there is sudden inflammation, acute inflammation. Okay, and what will be the onset for the chronic one? It will be delayed onset. The onset will be delayed. Okay, if I talk about the cells in acute inflammation, we have neutrophils, and here we have lymphocytes and macrophages. Okay, if I talk about sign and symptoms guys, we have prominent sign and symptoms in case of an acute, and in chronic guys we have milder. If I talk about tissue injury, we have mild tissue injury in acute inflammation, and here we have severe tissue injury in case of a chronic inflammation. Okay, now the sign and symptoms. Okay, so you already know this from your basic knowledge, okay, from your second year. Rubor, we have calor, we have dalor, tumor, and we have functiosa. Okay, we have functiosa. Okay, what do I mean by rubor guys? Redness. Rubor means redness. Calor means heat or temperature. Dalor means pain. Tumor means swelling. And functiosa means loss of function. And functiosa means loss of function. So this is the basics of the inflammation guys. What is an inflammation? It is a response to the injury. It's a response to the injury. Which injury guys? Vascular connective tissue injury. Okay, whenever the injury happens, the response to that is called as inflammation. Okay, chalo. Now further guys, now acute inflammation, we have two components. Acute inflammation, we have how many components guys? We have two components. What are the two components guys? We have a vascular change, the change that will take in the vessels, vascular change, and we have cellular change. We have vascular change and we have cellular change. Okay, if I talk about vascular change, okay, if I talk about vascular change, the first change in the vessels, there will be a vasoconstriction followed by vasodilation. Okay, the first one will be kya hoga pehle guys? So the first, what will happen? Vasoconstriction. First there will be a vasoconstriction. So what is a first change in inflammation guys? Acute one, the first change is, first change in inflammation is vasoconstriction. First change in inflammation is vasoconstriction. Now keep your mind physically, mentally be here, understand. Now starts the main topic. Okay, now where exactly the question will come from is the cellular change. Okay, we have to study about the events: margination, rolling, tight binding, diapedesis, transmigration, or the migration. Okay, and what can be the following disorders if there is a defect in the selectins, if there is a defect in the integrins. So what can be the following disorders? Now good question will come from such a topic. Okay, now they will not ask you what are the sign and symptoms, okay, difference between acute and chronic, है ना? They are now getting they are increasing their standards, so understand this much. Okay, now vasoconstriction is the first vascular change, followed by that guys vasodilation. उसके बाद क्या होगा? Vasodilation. Okay, and this vasodilation will be caused due to the release of histamine. It is due to the histamine. Now histamine is released, which causes vasodilation. Now histamine is coming from which amino acid? It comes from the histidine. It comes from the histidine. Okay, and what are the cells that release? Mast cells. Okay, chalo आगे After that guys, there will be a increase vascular permeability. ज़्यादा पानी अंदर जाएगा. Okay, more water inside. There is increase vascular permeability. Remember all these 4 steps. Increased vascular permeability, okay, which is a hallmark of acute inflammation. Question important: what is a hallmark of an acute inflammation, guys? It's increased vascular permeability. It's increased vascular permeability, okay. And in the end, there will be the stasis of the blood, okay. And when there is a stasis of blood, my dear students, there are increased chances of the thrombosis. When there is an increased chances of thrombosis, there's an increase, that means increased chances of the clot formation. We have a classical triad for that, guys. What is a triad? It's a varicose triad. What are the components of the varicose triad? We have stasis, we have endothelial injury, and we have hypercoagulability. Okay, guys, so write it down, guys. When there is a stasis, there are increased chances of thrombosis or clot formation. Thrombosis or clot formation. Okay, and particular triad, what is a triad? You remember, guys, it is called as varicose triad. क्या है triad का नाम? Varicose triad. So they can ask you, out of which of the following is not a component of a varicose triad? Okay, so what are the components? Sir, it's stasis of the blood, it's endothelial injury, पहले endothelial injury होगी, hypercoagulability. Stasis, endothelial injury, and the triad is called as varicose triad. Okay, so all the hypercoagulable states like pregnancy or the patient is a bedridden for the longer time. So what are the drugs we start, guys? We start anticoagulant drugs. That's why we always keep the patient on an unfractioned subcutaneous heparin when the patient is what? Bedridden for the longer time, because pregnancy as well, okay, because they are hypercoagulable states, increased chances of the clot formation, okay. Then the embolus will be there, okay. Different emboluses, you will see that the patient is having a deep venous history of deep venous thrombosis. He will have a pulmonary embolism. Patient in pregnancy, hypotension, hypoxia, and coagulopathy, having an amniotic fluid embolism. There is a fracture of a long bones femur, that fat globules go into the circulation, called as fat embolism. Deep sea divers are there, okay, guys, having a air embolism. So that are the different embolisms related to the medicine that you will study. But everything kahan se aata hai sab? Stasis. When there is a endothelial injury, vessels ki injury hoti hai, there is a clot formation, and then they can predispose to the bigger condition. So basics remember. Chalo, guys. So vascular change, guys, remember: vasoconstriction, vasodilation, increased vascular permeability, and stasis. And what is the hallmark of an acute inflammation, bacho? What is the hallmark? The hallmark of acute inflammation is increased vascular permeability, okay. Increased vascular permeability. Now chains inside the cellular chains, guys, we have intravascular chains of a cell inside a vessel and outside the vessel. Again, intravascular and extravascular. What are the cellular chains? Now what will happen to this cell? Okay, what will happen to this cell inside a vessel and outside the vessel? So see, guys, these all the events: margination, rolling, tight binding, okay, and half diapedesis, they are occurring inside the vessel lumen. They are occurring inside the vessel lumen. Then further the migration outside the lumen. So we have intravascular and extravascular. So starting with the first, guys, intravascular, the first chain that we are going to talk about is margination, okay. So what is the first thing we are talking about, guys? Margination. Now what is margination, guys? Remember, it's the movement of WBC from the center towards the periphery, okay. Now this WBC, okay, here it is moving from the center towards the periphery, okay. Now it is moving towards the periphery, and such a process is called as margination. Such a process is called as margination. So write it down, guys. Migration means movement of WBC. It means movement of WBC from center towards the periphery, from center towards periphery, from center towards the periphery. Okay, then guys, the second step, once this neutrophil, once this WBC guys, it is on the surface, okay, it's on the periphery. Now the second step that will take place is called as rolling. So what will happen in rolling guys? There is a loose attachment of this WBC with the endothelial cells. Okay, now these endothelial cells over here guys, okay, and this WBC, it will have a loose attachment, with the help of a molecules called as selectins, then we have a different types of selectins. Endothelial cells पे जो selectin होंगे we call them E selectins, platelets पे जो होंगे we call them P selectin, okay, lymphocytes पे जो होंगे we call them L selectin. So what is the first step? Now this WBC is moving from the center towards the periphery, having the first change intravascular called as margination. The second step, now this WBC guys, it is having a loose attachment with the endothelial cells. यहाँ पे attach हो रहा है ये with the endothelial cells with the special molecules called as selectins, or Slal-Lewis X. So write it down guys. Now the rolling, what is rolling guys? It's a loose attachment of WBC with endothelial cells. It's a loose attachment. It's a loose attachment of WBC with endothelial cell. With endothelial cells, okay, and this loose attachment of WBC with the endothelial cells, it is depend upon a special molecules called selectins. Special molecules called as selectins. Special molecules called as selectins and Slal-Lewis X. Okay, now here guys, you can see in the image. Okay, now see guys, this WBC, it is attached with the endothelial cells with the help of a selectin. Okay, now this selectin guys, it can be E selectin, it can be P selectin, it can be L selectin. Okay, so E on endothelial, P on platelets, L on lymphocytes. Okay, and which other molecule guys? Slal-Lewis X. Okay guys, Slal-Lewis X. Okay, then the next step guys, after there is a loose attachment, now there will be a firm attachment of WBC with the endothelial cells. Thus such a step is called as adhesion. Okay guys, so write it down guys. There is a firm attachment of WBC with endothelial cells. There is a firm attachment of WBC with endothelial cells. There is a firm attachment of WBC with endothelial cells. There's a firm attachment of WBC with endothelial cells, and molecules that are need for this addition, the molecules that are need for this firm attachment, they are called as integrins. क्या बोलते हैं guys उनको? Integrins. So remember guys, what are the molecules that are useful, that are used in the rolling? Selectins. What are the molecules for addition guys? Integrins. What are the molecules? Integrins. Okay, and these integrins, they will interact with molecules called as addition molecules. So what is addition, my dear students? Addition was, now yes, that will help them to go on. Okay, I will understand you the process. So they are attaching to these molecules and then they will move ahead so that they will come outside the vessel and they will be eaten by the opsonization process. That's why they are coming on these molecules. Okay. So now what are these addition molecules guys? They are ICAM and VCAM. Okay, vascular cell adhesion molecule and intracellular adhesion molecule. So write it down, guys. They are interacting with the adhesion molecules. They are interacting with the adhesion molecules VCAM. Okay, VCAM. What is VCAM, guys? Write it down. Vascular cell adhesion molecule. Vascular cell adhesion molecule, and another adhesion molecule called as ICAM, that is intracellular adhesion molecule. Intracellular adhesion molecule. Now this WBC, guys, see now this WBC, okay, tight binding is also called as adhesion. So don't worry, guys, if you see tight binding, adhesion is the same. Now see, all those students, now see, first of all, what was happening, this WBC from the center, it's coming to the periphery. Okay, then from margination is happening, then it is having a loose attachment with the endothelial cells with the help of a selectins. Then going more ahead, guys, it is having a tight additions or additions with the endothelial cells with the help of integrins. Then further, guys, there will be a transmigration. There will be a movement and they will try to come out of the what? Endothelium, so that there will be a opsonization, there will be a killing, so that's engulf will be there, phagocytosis will be there. So we are going a step by step, that the process which is taking place in a what? Inflammation. Okay, the events. Now if there is a defect in the adhesion molecules, now clinical correlation, guys, if there is a defect in these adhesion molecules, we have a disorders called as leukocyte adhesion deficiency disorders. Okay, what are the disorders, guys? We have a leukocyte adhesion deficiency disorders. So the LAD1, it is seen in defect of integrins. If there is a defect of integrin, guys, what will happen? LAD1. What is LAD, guys? Leukocyte adhesion deficiency disorder. Defect in the integrins. Okay, that is a adhesion molecule. What is integrin, guys? Adhesion. Okay, and integrin helps in the, write it down, tight bindness, tight binding or adhesion. Chalo. Now, guys, the patient of this LAD1, it is seen that the patient is having a recurrent infection. So patient is a history of a recurrent infections in LAD1. Recurrent infections. Okay, and there are neutrophils but no pus formation. Okay, what are the cells you will see here, guys? Neutrophils and no pus formation. So there is a, if defect, there is a defect in adhesions in LAD1. Okay, the LAD2, guys, it occurs due to the defect in selectins. It occurs due to the defect in selectins. And selectin helps in which, guys? They help in the rolling. Okay, rolling. Okay, or Cell Lewis X. Okay, और किसमें होता है defect, guys? Cell Lewis X. Lewis X. Okay, and the features of LAD2, features include short stature. Feature include short stature. Feature include short stature. Okay, and also, guys, recurrent infections are common. Recurrent infections are common in LAD2 as well. Okay, guys, if you go more precisely, what is an enzyme deficient in LAD2, guys? It's fucosyl transferase enzyme deficient. You don't need to remember for the FMGE, but yes, लिख लो for your extra knowledge. Fucosyl transferase enzyme deficiency. Okay, fucosyl transferase enzyme deficiency. So LAD1 guys, here it will be defect in rolling. इसमें होगा defect guys rolling, and वहाँ पे क्या होगा defect in additions. Okay, so the two, yes, severe MR, Bombay blood group, all there. Okay, yes. So two conditions guys, remember guys, LAD1 seen in a defect of integrins additions, and LAD2 occurs due to the defect in the selectins, remember, and integrins helps in the additions or the tight binding, and selectins helps in the rolling, and selectins helps in the rolling. Then guys, the next one we have diapedesis, which is also known as transmigration. Bracket में लिख दो guys, also known as transmigration. Okay, now what exactly happens in the diapedesis? Now this WBC molecule will move from inside the blood vessel, and it will try to move outside or throughout the basement membrane. Okay, so write it down guys, WBC molecule move from inside the blood vessel, move from inside the blood vessel through the basement membrane. Now this WBC molecule guys, it is coming out through the basement membrane guys, and such a process is called as migration. Okay, transmigration or diapedesis, and it is due to the molecule guys CD31 or PCAM or PCAM. Is it clear guys? CD31 or PCAM. So diapedesis. So remember guys, first of all, the WBC is coming from center to the periphery. Then further there is a loose attachment, then a firm attachment, then the diapedesis guys, and further there in the end there will be a migration. So guys, we have reached up till where? We have reached up till the diapedesis. So all these four events, whether the diapedesis, whether the tight binding, whether the rolling or margination, they are intravascular events. Now the migration guys will be a extravascular event. So what are the molecules that are helping in the rolling guys? In rolling, what are the molecules that are helping? Write down in the comment section fast guys. Rolling में कौन help करते हैं? Selectins, RS. So remember guys, PQ, RS. S is closer to the R, so selectins are helping in the rolling. Remember it this way, integrins are helping in the additions. If there is a defect in these addition molecules, we have a leukocyte addition deficiency disorders, LAD1 and LAD2. Okay, LAD1 mainly with the integrins, LAD2 with the selectins. Now extravascular chains. Now after this, when the WBC is out from the basement membrane, okay, it moves to the site of infections under the influence of the process. Now what is the process when this WBC is out of the basement membrane? It is called as chemotaxis. Okay, now it is chemotaxis. Externally, exogenous bacterial products are helping. Bacterial products and endogenous factors. In endogenous factors guys, we have leukotrienes, LTB4. Okay, we have interleukin 8, and we have complement C5a. Important guys. Extravascular chains mein what are the endogenous factors that are helping? The endogenous factors are leukotrienes, interleukin and C5a. Okay, and the last step will be the phagocytosis. Okay, nice. Now it will be a phagocytosis. In phagocytosis, we'll have three steps. We'll have opsonization, we have engulfment, and we'll have killing. We'll have opsonization, engulfment, and killing. All these are the MCQs guys. Now for opsonization, we need an opsonins. What are the opsonin molecules? So it depends on the molecules called opsonins, depend on molecules like कौन कौन हेल्प करता है गाइस? C3b, IgG, C3b, IgG, C-reactive protein, and lectin. Most potent option guys, C3b. Then guys, engulfment guys. Now this, there will be an engulfment of this WBC guys with the help of an active polymerization. Okay, it is associated with the pseudo extension. It will engulf this particle now, and after engulfing guys, there will be a killing. Pseudo extension. Okay, and then there will be a killing. Okay guys, there will be a killing dependent either on oxygen or not depend upon the oxygen. That will be the last step. Now while this killing guys, we need a protein guys. There is a lysosomal transferrin protein called as list protein. क्या नाम का प्रोटीन का guys? It's a list protein. Okay, what is this protein? It's the lysosomal transfer protein. It's a lysosomal transfer protein, helps in the killing. And if there is a defect of this protein, my dear students, if there is a defect of this protein, we have a classical condition called as, what is the name of the syndrome? We have Chidiac-Higashi syndrome. We have Chidiac-Higashi syndrome. So list protein defect, we have Chidiac-Higashi syndrome. What are the classical features guys? C for CNS features. C for CNS features, I'm writing it here. C for CNS features. HE for hemorrhage. DI for decreased immunity. DI for decreased immunity. AK for albinism. AK for albinism. Okay, so Chidiac-Higashi syndrome guys, you will remember guys that patient will have CNS features, hemorrhage, decreased immunity, and albinism. Okay, on peripheral blood smear, on PBS, on peripheral blood smear of a Chidiac-Higashi syndrome patient guys, there are giant granules in the cytoplasm. Giant granules in cytoplasm. Okay, so remember that as well. Okay, so remember guys, list protein defect, Chidiac-Higashi syndrome. Okay, what is list protein? It's a lysosomal transfer protein used in case of a killing during the phagocytosis. Now you will remember guys, one more point here. There is a formation of a hydroxyl radical guys due to the activity of myeloperoxidase enzyme, which is responsible for the killing of bacteria. Okay, so what exactly happens guys? A respiratory burst occurs. You have studied back in the ROS as well and biochemistry as well. So respiratory burst is occurring with the help of an enzyme called as NADPH oxidase, and this NADPH oxidase, it's also called as respiratory burst oxidase enzyme. The oxygen dependent killing guys, it is also called as NADPH oxidase as well as respiratory burst oxidase enzyme. And the thing you have to remember, the question important, that the deficiency of this enzyme, if there is a deficiency of this enzyme, we have a classical condition called as chronic granulomatous disease. If there is a deficiency of NADPH oxidase, what is the condition guys? Chronic granulomatous disease. Chronic granulomatous disease. Okay, the patient of this chronic granulomatous disease guys, he'll have a repeated attacks of infections. Patient will have a repeated attacks of infections. Patient will have repeated attack of infection due to the catalase positive organisms. Due to the catalase positive organism. Number one. Number second guys, in chronic granulomatous disease, there is a formation of granuloma as well. There is a formation of granuloma in the organs. I will teach you shortly the different granulomas and in the different conditions. The diagnosis is with the NBT test, nitro blue tetrazolium test. Again a question guys, diagnosis, what is the test guys? NBT test, which is called as nitro blue tetrazolium test. Nitro blue tetrazolium test. Okay, and about this test guys, if there is blue color, अगर टेस्ट के बाद ब्लू कलर cells, so it's normal. If no color, then the patient is having chronic granulomatous disease, CGD, chronic granulomatous disease. Very good. There is a defect, the gene defect is called as Fox gene defect. There is a Fox gene defect. Very good. Fox gene defect. Now can any one of you tell me, now you told me Fox gene defect, very good. Now Sox gene defect, which condition? Anyone? Sox gene defect. अब Fox तो बता दिया, Sox बता दो. Fox, Sox, Sox gene defect किस condition? What is the condition? Sox gene defect और Sox बता दो. Fox you know, chronic granulomatous disease. अब Sox बता दो. SHOX, Sox. I'll give you the hint guys. Streak ovaries, short stature, shield chest, bicuspid aortic valve stenosis is the most common cardiac defect. It's trisomy, sorry, it's monosomy. Which one? Which syndrome guys? Monosomy 45XO. Turner syndrome. In a short stature, the gene defect is Sox gene, SHOX, Sox gene defect. Is it clear guys? Very good. Fox gene defect, Fox gene defect. So it is also called as, NADPH is also called as respiratory burst oxidase enzyme. NADPH, it is also known as, it's also known as respiratory burst oxidase enzyme. Respiratory burst oxidase enzyme. Okay, and remember guys, the pattern is XLR followed by autosomal recessive, X-linked recessive, autosomal recessive. So it's all about chronic granulomatous disease, chronic granulomatous disease. Okay, Fox gene defect, remember guys, patient is having a recurrent infection and there is a formation of a granuloma as well, Okay, now the further guys, the chemical mediators. Now let's discuss about the chemical mediators. What are the mediators? Now we have three types. We have cellular preformed, we have cellular fresh formed, and we have plasma. Okay, now first one guys, cellular preformed. We have histamine, we have serotonin, and we have lysosomal enzymes. If I talk about cellular fresh formed, we have nitric oxide, we have arachidonic acid metabolites, we have arachidonic acid metabolites, and we have cytokines. These are the cellular fresh form. Okay, then in the plasma guys, we have kinin system, we have complement system, we have kinin system, we have complement system, and we have coagulation system. Now let's discuss one by one, guys. Fast. Let's discuss about these chemical mediators. Now let's discuss about these chemical mediators. If I talk about the first one, guys, histamine. Okay, the richest source of the histamine is which cell, guys? Mast cells. The richest source of histamine, we have which cells? We have mast cells. We have mast cells. Okay, it's also released by, just remember mast cells only. Okay, you don't remember much. Richest source is mast cells. Okay, then it is derived from histidine. Basophils and platelets are also there, but you remember mast cells. Derived from histidine. Derived from histidine. Okay, and then, guys, it causes vasodilation. ये क्या कराता है, guys? Vasodilation and increase in vascular permeability or increase in permeability. Okay, guys, you also remember, guys, histamine जब ज़्यादा होता है तो क्या होता है? When there is a more histamine, what will happen? Bronchospasm. Also, what will happen, guys? Itching. इसीलिए for itching, what we give? Mast cell stabilizers. We give very good drug, antihistamines. We give blastine. Bronchospasm. Then the nitric oxide, guys, it is derived from amino acid. Sarkari question. Okay, very famous question. Derived from arginine. Multiple times asked. Arginine. Okay, and then you also remember, guys, what is released? Nitric oxide. That's what is the mechanism of action of a nitrates, by releasing nitric oxide derived from arginine. It causes both vasodilation and free radical formation. It causes both vasodilation. It causes both vasodilation and free radical formation. And free radical formation, and causes both vasodilation and free radical formation. The most important chemical required in the process of acute inflammation. What's the most important one, guys? Serotonin. Now this serotonin, it has a both function of vasoconstriction and vasodilation. Vasodilation and vasoconstriction. Okay, and what are the source? What is the source, guys? Argintophane cells of GIT. वैसे tryptophan से आता है, but here argintophane cells of GIT. Argintophane cells of GIT. Argintophane cells of GIT. Okay, serotonin, melatonin, है ना, all coming from the tryptophan. Okay, there is a syndrome, classical syndrome, क्या नाम है? Carcinoid syndrome. Tell me anything about carcinoid syndrome faster, guys. Carcinoid syndrome. Investigation of choice 5-hydroxyl indole acetic acid. Okay, remember, guys, Kulczewski cells. Which cells? Kulczewski cells. And what is the drug that is given in case of a carcinoid syndrome, guys? It's a somatostatin analog called as octiotride. What is the class of the octiotride, guys? Somatostatin analog. Remember the class of the drugs, guys. They can ask anything. Somatostatin analog. As much as possible integration is there, I'm doing. So carcinoid syndrome. So remember everything about carcinoid syndrome. 5-hydroxyl indole acetic acid, Kulczewski cells, and drug of choices octiotride. This is the same octiotride that we use in the acromegaly. Acromegaly में भी use होता है. Okay, चलो serotonin. Okay, so serotonin 5-HT3 है ना, you already know that. चलो further. Now it was all about, guys, cellular formed histamine, nitric oxide, and serotonin. Okay, now let's go further, guys. Arachidonic acid pathway. Arachidonic acid pathway. Now in arachidonic acid pathway, guys, you might have studied in biochemistry as well पढ़ाई होगा. In arachidonic acid pathway guys, whenever there is a tissue injury, सबसे पहले क्या हो गई, tissue injury. So there is a injury to the phospholipid cell membrane. Okay, when there is a, yes, esophageal varices also, but esophageal varices में अभी we give terlipressin and then followed by octreotide. Acromegaly में भी देते हैं octreotide, pigvostamat भी देते हैं, that is a growth hormone antagonist in acromegaly, and esophageal varices में terlipressin followed by octreotide. The other conditions as well where we can use this somatostatin analog. It is in carcinoid syndrome. What exactly are the features of the carcinoid syndrome? Patient is having a watery diarrhea होता है patient को, that's why it's also we use somatostatin analog. चलो, the injury to the phospholipid cell membrane, it will release the arachidonic acid. Okay, once there is an injury to the tissue guys, the cell membrane is damaged and there is a release of arachidonic acid. And now this arachidonic acid guys, two pathways you'll remember, COX and LOX. So cyclooxygenase pathway and lipooxygenase pathway. Okay, this cyclooxygenase pathway guys, what are the outcomes, what are the drugs, what are the hormones will come? Prostaglandin will come. Okay, prostaglandin G2, prostaglandin H2, prostacyclin will come, and thromboxane will come from the COX. Okay, and from the LOX what will come guys? Leukotrienes, different leukotrienes. Now if I talk about the drugs that will inhibit COX1 and COX2, what are the drugs that will inhibit? Sir, aspirin and indomethacin. Aspirin and indomethacin. Okay, COX2 में etorcosib and all the drugs that inhibit. Okay, then guys, prostacyclin. Okay, what will prostacyclin do guys? It will cause vasodilation. Prostacyclin क्या कराएगा? It will cause vasodilation. Further guys, what also it will cause? It will cause inhibition of platelets. It will cause inhibition of platelets as well. Then guys, prostaglandin, pain, inflammation and vasodilation. Thromboxane will cause what guys? Vasoconstriction and platelet aggregation. Vasoconstriction and platelet aggregation. Okay, in here guys, leukotrienes, you know asthma में क्या होता है raised guys, leukotrienes are raised and they will cause bronchoconstriction, asthma attack and smooth muscle contractions. That's why what are the drugs we will give guys that will stop the leukotrienes. Okay, the question guys, if you have a question, what are the leukotriene receptor antagonist? Write down in the comment section guys, what are the drugs? Leukotriene receptor antagonist. The drug we have is montelukast and zafirolocast. Montelukast and zafirolocast. If you have a lipooxygenase drug, directly works on the lipooxygenase LOX pick, that is xylitol. That is LOX inhibitor xylitol. If it's a receptor antagonist, montelukast and zafirolocast. That's why both the drugs are used in what? Asthma, because leukotrienes are responsible for what? They are responsible for bronchoconstriction and smooth muscle contraction. Then further we'll give vasodilators, beta agonists that will act on the lungs directly, वो बाद में. But here guys, from leukotrienes you remember montelukast, zafirolocast, remember xylitol. Here remember guys, prostaglandins cause vasodilation, thromboxane A2 particularly cause platelet aggregation. Here COX1 COX2 में aspirin, indomethacin. Remember all this about an arachidonic acid pathway. Is it clear? Now then further guys, we have cytokines. Okay, we have cytokines. Now what exactly are cytokines? They are the proteins which are released by the activated cells. They are proteins released by activated cells. They are proteins released by the activated cells. Okay, now what are the proteins guys? What are these activated cells? These can be neutrophils, lymphocytes, macrophages. लिख ही देता हूँ. They can be neutrophils, lymphocytes, macrophages. Okay, now pro-inflammatory cytokines. What are the pro-inflammatory cytokines? We have interleukin 1. Remember, it's all important, guys. We have interleukin 1, we have interleukin 6, and we have TNF alpha. Okay, guys, we have TNF alpha. Okay, now day before yesterday, when we are talking about an extrinsic pathway, I've taught you that there is a tumor necrotic factor, okay, involved in case of fast ligand TNF, all involved in case of an extrinsic pathway. At over there, I told you that this TNF, it is a what? It's a cytokine. It's a cytokine. Okay, now what is the function, guys? What exactly is happening? Now, due to these cytokines when are released, interleukin 1, it will cause pyrexia, it will cause fever. And I've already discussed that this interleukin 1, it is involved with the help of which caspase? Caspase 1 activates interleukin 1, and interleukin 1 is responsible for the fever, and the drug that will inhibit this interleukin 1 is called as anakinra. It's called as anakinra. So fever, interleukin 6, malaise. And my dear students, weight loss. Which cytokine is responsible for the weight loss? It is tumor necrotic factor alpha, TNF alpha. So weight loss, please remember this, weight loss with TNF alpha. So weight loss and TNF alpha, remember this. Okay, then anti-inflammatory, guys, we have a interleukin 10 and TGF beta. We have interleukin 10 and TGF beta, tumor growth factor beta. And remember guys, this TGF beta has fibrogenic cytokine. It's a fibrogenic cytokine. It is a fibrogenic cytokine. Okay, and it helps in the wound healing. इसमें help करेगा wound healing, TGF beta. Then guys, we have a dual action of two interleukins, interleukin 4 and interleukin 6. What's the drug that will inhibit interleukin 6? It's a tocilizumab and sarilumab, which is responsible for the cytokine storm. Okay, so interleukin responsible for the cytokine storm, we have tocilizumab and sarilumab. Okay, and which cytokine has a weight loss associated with the weight loss? TNF alpha. Which cytokine has a fibrogenic cytokine or a cytokine associated with the wound healing? TGF beta. Okay, then we have interferons, guys. Okay, write it down. We have interferon alpha, beta and gamma. We have alpha, beta and gamma. Okay, and they are responsible for granulomatous inflammation. They are responsible for granulomatous inflammation. Then we have chemokines, guys. They attract the neutrophil and lymphocyte. They attract neutrophil and lymphocyte. They attract neutrophil and lymphocyte. Is it clear, guys? Is it clear? Cytokines. So we have pro-inflammatory, guys, interleukin 1, interleukin 6, TNF alpha, fever, malaise and weight loss. We have anti-inflammatory cytokines, guys, interleukin 10, TGF beta, which is having a fibrogenic cytokine, helps in the wound healing. We have a dual action with the help of interleukin 4 and interleukin 6. Interferons alpha, beta, gamma, which are responsible for the granulomatous inflammation, and chemokines, which are responsible for the attraction of neutrophils and lymphocytes. Attraction of neutrophils and lymphocytes. Okay, then guys, in the kinin system, remember guys, in the kinin system, write it down, the factor 12, which is also called as Hegeman factor. Okay, it can activate, okay, it can activate the formation of can activate the formation of coagulation cascade. Coagulation cascade, okay, and cause bradykinin. It causes also a release of bradykinin, okay, and it helps in the fibrinogenic pathway or fibrinolytic pathway. So okay, so what happens, guys, this Hagman factor, guys, it activates the bradykinin, guys, formation of the bradykinin, which helps in the coagulation cascade and fibrinolytic pathway, okay. And this bradykinin, what will this bradykinin do here, guys? It can increase the permeability and pain. It can cause pain and increase permeability. Pain and increase permeability, okay. Then so kinin system, guys, there is a bradykinin activation which helps in the fibrinolytic pathway and the coagulation cascade. Simple thing, kinin system, okay. Then the complement pathway, guys. This complement pathway, it consists of more than 20 proteins, guys, and these proteins are responsible for an immunity, whether that's an innate or an adaptive immunity, okay. What is the function of this complement pathway, guys? The function is opsonization, chemoattractants, and cell lysis, okay. So in this complement pathway there are multiple proteins, guys, multiple complements, C1, C2, C3, C4, okay. And what exactly are these complements doing? These complements are helping in case of an immunity, innate and adaptive immunity. And if there is a deficiency of these complements, guys, yesterday I've taught you that most common complement deficiency is C2, okay. There can be autoimmune disorders, okay, there can be SLE, there can be the infections and such conditions. Which type of necrosis is associated with such diseases, guys? Fibrinoid necrosis. So autoimmune conditions, there is a complement pathway. So what are these complements? These are the proteins. So what is the function here, guys? We have pathways, we have alternate pathway, classical pathway, and lectin pathway. You have to remember, my dear students, that opsonization, what is the function, guys? Opsonization with the help of an opsonins, okay. Remember, guys, C3b, C4b, and C5b, okay. C3b, C4b, and C5b. Chemoattractants, what are the chemoattractants? We have C5a, C3a, and C4a, okay. And cell lysis with the help of a membrane attack complex, guys, C1 to C9, sorry, C5 to C9. The membrane attack complex, C5 to C9, that is C5, C6, C7, C8, C9, okay. The most common complement deficiency, this is the formation of the membrane attack complex, guys, C5 to C9. The most common complement deficiency is C2. Most common complement protein deficiency, most common complement protein deficiency, we have C2, okay, mainly seen with SLE. SLE में आता है, ठीक है guys, SLE. Now you autoimmune disorders, fibrinoid necrosis, type 3 hypersensitivity, C2, SLE, also SLE is having type 3 hypersensitivity, so integrated, correlated, ठीक है guys. So that was all about a complement pathway. Then chronic inflammation. We have 25 minutes, guys, we need to finish this inflammation, okay. Then the chronic inflammation, okay. Now when there is a long duration inflammatory process which is characterized by tissue destruction. Now long duration inflammatory process which is characterized by tissue destruction is called as chronic inflammation. In acute inflammation, what was the hallmark of the acute inflammation? Increase vascular permeability. But here, what will be the hallmark of a chronic inflammation, guys? There will be a tissue damage or the tissue destruction. There is tissue damage or tissue destruction. I want to complete this inflammation chapter today only. Tissue damage or tissue destruction, okay. Now guys, this infiltration is caused by the mononuclear cells, macrophages, and lymphocytes. So different organs have a modified macrophage. So let's tell me fast guys. In liver we have which macrophage? What are the cells of the liver macrophage called? Kupffer cells. If I talk about spleen guys, we have littoral cells. In spleen we have littoral cells. In kidney we have mesangial cells. In kidney we have mesangial cells. In brain we have microglial cells or Gitter cells. Microglial cells or Gitter cells. Okay, in placenta already discussed, we have Hofbauer cells. Okay, in bone we have osteoclast, bone destruct macrophage, bone formation osteoblast, osteoclast. One more you will remember, my dear student, lungs. What are the macrophages of the lung called? Dust cells. Macrophages of the lung are called as dust cells. So it was all about the macrophage. So liver is Kupffer cells, spleen is littoral cells, kidney is mesangial cells, brain is microglial, placenta Hofbauer cells, bone osteoclast, lungs dust cells. Okay, and the activated macrophages, they are responsible for the formation of an epithelioid cell. Okay, these activated macrophages, okay, they are responsible for the formation. क्या बनाएंगे further guys? Epithelioid cells. And this all these cells will combine, all these cells. Okay, now there is a central area of inflammation surrounded by the macrophages, lymphocytes, plasma cells, and all together it is called as granuloma. क्या बोलेंगे साथ में सबको guys? Granuloma. So look at here guys, the macrophage guys, the activated macrophage will be formed the epithelioid cells, then along with the lymphocytes, giant cells, plasma cells, there will be a formation of a granuloma. There will be a formation of a granuloma. Now we have a subtypes of granuloma guys. The first one we have granuloma, which is called as soft granuloma, seen in case of a TB, seen in case of a TB, caseating granuloma. So let's write it down guys. In TB, which type of necrosis is taking place guys? There is a caseous necrosis. TB में कौन सी necrosis होती है guys? There is a caseous necrosis, cheese-like appearance, caseous necrosis. So write it down. There is a presence of central necrosis. There is a presence of central necrosis and giant cell. There is a presence of central necrosis and giant cell, which is called as, what is the giant cell of the TB called as guys? The giant cell of the TB is called as Langhans giant cell. The giant cell of the TB is called as Langhans giant cell. Okay, and the granuloma is also known as, the granuloma is known as soft granuloma. The granuloma is known as soft granuloma. It's known as soft granuloma. Okay, if I talk about sarcoidosis, bilateral hilar lymphadenopathy, KVM test, okay, all together. So write it down guys. There is no caseous necrosis. There is no caseous necrosis. There is non-caseating granuloma. There is non-caseating granuloma. Okay guys, there are less mononuclear cells. Giant, वहाँ पे होती है Langhans giant cell. Okay guys, horseshoe shaped nuclei. Yes, less mononuclear cells. And it's also known as naked granuloma. It's also known as naked granuloma. Okay, now this is a caseating granuloma guys. TB में दिखता है caseating granuloma. Okay, and here guys, the less mononuclear cells with no caseous necrosis. Okay, and this is seen in sarcoidosis, called as non-caseating granuloma. We have non-caseating granuloma. Non-caseating granuloma. Okay, so caseating in the TB, non-caseating in the sarcoidosis. Central necrosis, caseous necrosis in the TB, sarcoidosis, there is no caseous necrosis. Now guys, tell me fast, the satellite granuloma. Which disease? Satellite granuloma. Satellite granuloma. It is seen in the disease called as cat scratch disease. किसमें दिखता है? Cat scratch disease, which is caused by cat scratch disease. It is caused by Bartonella Hensley. Okay, then this one guys, donut shaped granuloma is seen in which fever? Q fever. Write it down guys. Donut sign on रेडियोलॉजी में डोनट साइन किस में दिखती है? एनीवन इन द कमेंट सेक्शन गाइस. सो डोनट ग्रैनुलोमा कहाँ पे गाइस? क्यू फीवर. क्यू फीवर इज कॉज बाय कॉक्सिला ब्रूनेटी. कॉक्सिला ब्रूनेटी. इंटरसेप्शन, वेरी गुड. डोनट साइन है ना. रेड कलर जेली स्टूल्स, सॉसेज शेप लंप, डोनट साइन है ना. ल्यूमिन इनटू द ल्यूमिन, इंटरसेप्शन है ना. साइड इफेक्ट ऑफ अ विच वैक्सीन? रोटा वैक्सीन. ऑल अबाउट इंटरसेप्शन. दिस इज अ डर्क ग्रैनुलोमा सीन इन मलेरिया. डर्क ग्रैनुलोमा किसमें दिखता है गाइज? It is seen in malaria. Okay, then malaria is caused by the plasmodium. Which plasmodium? It can be plasmodium vivax, it can be plasmodium falciparum, it can be plasmodium ovale, or it can be plasmodium malariae. Okay, then we have a rapid diagnostic kit in the malaria guys called as, which detects the protein histidine of which protein. LDH levels we also check. We take two smears, thin and thick. One will tell about the species, another will tell about the confirmation of a malaria. Okay, then the treatment based upon northeastern states and other states that we have already discussed. Okay, and this type of granuloma guys, last one, it is a gamma seen in the syphilis. Okay, syphilis is caused by the on dark field microscopy spiral shaped, okay, Treponema pallidum. Drug of choice for syphilis, benzathine penicillin. So it was all about main granulomas. Okay, we have one more granuloma guys, write it down. We have donut syphilis. Okay, that's a giant cell. Okay, chalo. Now important giant cells guys. Okay, now important giant cells, we have Langhans giant cell seen in TB. We have Ashkoff giant cell, already know guys. Which necrosis? Fibrinoid necrosis in rheumatic heart disease with the criteria, Jones criteria. We have Reed-Sternberg cell, oval eye appearance, कहाँ पे मिलती है? Hodgkin's lymphoma. We have Warthin-Finkeldy giant cell seen in case of a measles, है ना. About the measles, remember guys, the rare complication as subsclerosing panencephalitis. ठीक है ना. Which what else you remember from the measles guys? 4 days before the rash, 5 days after the rash. Okay, there is a line on conjunctiva called as Stimson's line. There are the spots present and the opposite to the second molar called as Koplik spots, है ना. The name of the strain of the measles vaccine is Edmonster Zagreb, है ना. All these things you remember about a measles, है ना. So what are the giant cell? Warthin-Finkeldy giant cell. In sarcoidosis we have a bodies called as asteroid bodies and Schwann bodies. Okay, one more giant cell guys, remember, we have a Taunton giant cell seen in xanthoma. Taunton giant cell कहाँ पे दिखती है? xanthoma में. Xanthoma, intranuclear intracytoplasmic antibodies. Yes, all everyone is right. Good. So this was all about giant cells. Repeatedly guys, you have already studied these giant cells multiple times. Okay, Now then further guys, we'll discuss about a wound healing. Now we'll discuss about a wound healing on a particular day. What are the following steps? So remember guys, on day 0, what is day 0? The same day. What will happen guys? Blood clot. Blood clot. Okay. On day 1 guys, blood clot and neutrophilic infiltration. Neutrophilic infiltration. Day 2 guys, there will be thin epithelial cell coverage. Thin epithelial cell coverage. Day 3 guys, granulation tissue appearance. Granulation tissue appearance. Okay, then further guys, there will be angiogenesis, 4th 5th day, formation of the new blood vessels. After 2 weeks guys, there will be increased collagen and fibrous tissue. Increased collagen and fibrous tissue. And remember guys, 1 week the wound strength will be 10%, 3 months 70%, but never 100%. Never 100%. It's same in case of a bone fracture as well. Okay, then we have a primary wound healing and a secondary. Primary for the clear wounds and secondary for the white wounds. Then the hallmark of a wound healing is deposition of granulation tissue. Deposition of granulation tissue. Deposition of granulation tissue. Now this deposition of granulation tissue has 3 components. Remember the components of this. What is the hallmark of the wound healing guys? Deposition of a granulation tissue. There are 3 components. Write it down guys. 3 components. Component number 1 guys, mononuclear cells. Second, there will be a neovascularization, the same that we have wrote. Angiogenesis, neovascularization, and collagen and fibrous tissue. Collagen and fibrous tissue. Okay, now the collagen types guys. Type 1 collagen, it's seen in bones, you already know this. Type 2 seen in cartilage. Type 3 with scar formation, and type 4 in the basement membrane. We have discussed multiple times guys, basement membrane defect, Alport syndrome, and a basement membrane. Okay, the vitamin required for the wound healing guys, which vitamin? Vitamin C. Okay, vitamin C. That's why if there is a deficiency of the vitamin C, we have poor wound healing, along with the zinc as well. Okay, the cell responsible for wound contraction is myofibroblast. Myofibroblast. It's myofibroblast. Okay, so it was about a wound healing. Now if there will be a abnormal wound healing guys, there will be a 2 condition. Either there will be a hypertrophic scar or the keloid formation. Okay guys, hypertrophic scar or the keloid formation. Now first one guys, this one, which is hypertrophic scar. Okay, so what are the features of this hypertrophic scar? Remember guys, it's a rapid growth, then there is a spontaneous resolution after some time. Okay, first it will grow faster, but then there will be a decrease in the growth after time. Okay, it will be acute guys. There is no specific cause. Okay, what do I mean by cause guys? Distribution. It is not seen with the family history or the pigmented skin, while as keloid, it is having a history of a pigmented skin. The symptoms guys, there is a itching due to the mast cells guys, but here there is pain and sensitivity as well. If I talk about here guys, here is a well organized type 3 collagen. Okay, collagen that is useful for the scar formation. I've mentioned here, guys, type 3 scar formation. Okay, but here it's poorly organized or decreased ratio of the type 3 type 1 collagen. That is why it is crossing the boundaries as well. Okay, this is a keloid. This is a keloid. If I talk about area, guys, it is limited to the original wound. Okay, if there is an incision, guys, here on the abdomen, you can see it is limited to the what, the wound incision. Okay, but keloid, what is happening, it is extend beyond the original wound. Okay, keloid is going beyond the original wound. Okay, recurrence, there is no recurrence in case of an hypertrophic scar, but in case of a keloid there is a recurrence. Okay, so remember, guys, keloid, it does not self resolve. Okay, and it can come anytime after the injury. It can come anytime after the injury. Now keloid most common location, it is seen on sternum. कहाँ दिखता है mainly, guys? It's seen on sternum. Okay, and anyone, what is the treatment for the keloid, guys? We give injection to the keloid directly, called as triamcinolone. Injection to keloid, triamcinolone. So it was all about an abnormal wound healing, that is hypertrophic scar and keloid. Okay, so that was all about inflammation. Is it clear, guys? So let's have a quick recap of all the things that we have studied in part 1 and part 2, and then we stop the class. Is it clear, guys? Wound healing, guys, it was an easy one. I went a bit faster, but it's okay. Already I've studied the macrophage, scuffer cells, dust cells, mesangial cells, and the giant cells are all repeated. Okay, now let's discuss fast whatever we have studied today, guys. So we started from the pigments. Okay, the pigments, the first pigment that we have studied was the lipofuscin, guys, which is also called as wear and tear pigment, or the pigment of aging. It's more commonly seen in the aging cells like liver and heart. Okay, then the melanin, guys, it's a tyrosine derived pigment. Remember the albinism and the enzyme deficient tyrosinase. Okay, it's responsible for the color of skin, hair and eyes. That's why it's also called as oculocutaneous disorder. Hemosiderin, it's an iron derived pigment, guys, which is seen in the condition having a chronic iron overload like thalassemia, multiple blood transfusions, or the chronic hemolytic anemia. The stain that we use is the Prussian blue stain, the reaction Pearl's blue reaction. Remember the image as well, guys. Then amyloid is an extra proteinaceous deposition in the organs, guys. The stain that we use is Congo red stain, and it gives the appearance apple green birefringence under the polarized microscopy. Then an exogenous most common pigment, we have an anthracotic pigment seen in the patient having a long history of smoking, and as well as the patients exposed to the coal dust. Okay, if there is a rheumatoid arthritis plus anthracosis present, we call it as rheumatonemoconiosis, which is a classical name having a Kaplan syndrome. If splenomegaly as well, you go with the Felty syndrome. Okay, it's common in the smokers, that's why it's also called as black lung. Then the glycogen storage diseases, where there is an accumulation of the glycogen in the muscles of liver. Okay, and the stain that we use is PAS stain. Then the types of calcification, guys, we have dystrophic and metastatic calcification. Dystrophic is dead or degenerated tissue. Remember the serum calcium levels are normal. The association conditions, you can remember TRAT M, tuberculosis, rheumatic heart disease, atherosclerosis, tumors, myositis ossificans, and Monckeberg sclerosis and infections, where the myositis ossificans is a classical example of a connective tissue metaplasia. Then, guys, if I talk about a metastatic calcification, you have an association with the parathyroid adenoma, serum calcium levels are high, there's a hypercalcemia, sarcoidosis, primary hypoparathyroidism, and all. Okay, then the calcium staining for the minimal, you have alizarin red. For the high, von Casa stain. For collagen, we have Masson trichome. For nucleic acid, you have acridine. For mast cells, you have toluidine. For fungal, we have GMS. And for reticulin fiber, you have sweet reticulin test. Then the inflammation, guys, acute and chronic. Okay, the onset is sudden and delayed. Then the vascular change in the acute inflammation. Remember, first there will be a vasoconstriction. That's the first change in the inflammation, followed by that, due to the histamine which is released from the mast cells, it will cause a vasodilation, Further, there will be an increased vascular permeability, which is a hallmark of an acute inflammation, and then the stasis of the blood, which can lead to the chances of thrombosis or the clot formation. The triad classical is called as a virtuous triad: stasis, endothelial injury, and hypercoagulability. Remember, they will tell you which of the following is not a component. Hypocoagulability is not a component. Okay, remember, hypercoagulability, stasis, and endothelial injury. Then the cellular chains inside the lumen of an endothelium, guys, will have a first margination, where the WBC will move from center towards the periphery. Then further, there will be a rolling with the help of molecules called as selectins and Slal-Lewis X. What will happen? There will be a loose attachment in the rolling, followed by there will be a firm attachment in additions with the help of integrins. And then if there is a defect in these addition molecules, we have a LAD1 and LAD2. Integrins with the LAD1 and LAD2 with the selectins. Patient will have a features of a recurrent infection. So the defect in the rolling is seen in LAD2. Then the transmigration, guys, this WBC will move from inside the blood vessel through the basement membranes, and that is called as diapedesis, also transmigration. So these were the intravascular events that has taken place inside the vessel. Then further, guys, extravascular events, there will be a chemotaxis, and endogenous factors like the bacterial products will help, and the exogenous will the bacterial products, and endogenous will be your interleukins, leukotrienes, and complement C5a. Then the phagocytosis, guys, 3 steps. There will be opsonization. It will depend on the molecule like C3b, so that they will directly check them and make this WBC tastier. So they will opsonize them, recognize them, and then further with the pseudo extension they will engulf them, and then the killing. The protein is less protein. If there is a defect, is a Chediac Higashi syndrome with the CNS features, hemorrhage, and albinism. And the classical peripheral blood smear will have a giant cytoplasm. Okay, guys, giant granules in the cytoplasm. And if the enzyme that is used is respiratory burst oxidase, which is an NADPH oxidase enzyme, depend on oxygen dependent killing mechanisms. If there is a deficiency of that enzyme, it will cause a disease called as chronic granulomatous disease. So what is the diagnosis, guys? It's a diagnosis is done with the help of a nitro blue tetrozolium test. If there is a blue color, normal. If no color, that goes with the chronic granulomatous disease. There is a Fox chain defect, guys, and patient is having a recurrent infection due to the catalase positive organism. Then chemical mediators, guys, histamine, which is released by the mast cells, derived from the histidine, and it causes vasodilation. Okay, then nitric oxide derived from the arginine, guys, it causes vasodilation and free radical formation. Then chemical which is required in the process of acute inflammation, serotonin, guys, vasodilation and vasoconstriction, both. The source is argentafin cells of GIT. It comes from which amino acid? Tryptophan. And the carcinoid syndrome, remember, guys, all these are the questions that I'm writing side by side. 5-hydroxyl indole acetic acid is the investigation of choice, and the drug of choice your somatostatin analog octreotide. Patient का symptom क्या होता है? Watery diarrhea. Then the arachidonic acid pathway, my dear students. When there is a tissue injury, there is a cell membrane damage which releases the arachidonic acid. Then these arachidonic acid metabolites have 2 pathways. We have cyclooxygenase pathway and lipooxygenase pathway. Cyclooxygenase pathway will give prostaglandins, prostacyclins, and thromboxane. Then further, prostacyclins, vasodilation; thromboxane, vasoconstriction; prostaglandin, vasodilation, and platelet aggregation with the thromboxane. Okay, and leukotrienes will cause a bronchospasm, smooth muscle contraction, and the drug which will act on the leukotriene receptor is a montelukast and zephyrolocast, and the drug which will act on the LOX, lipooxygenase inhibitor, that is a xylitol. Okay, COX-1, COX-2, aspirin, and indomethacin. Then we have cytokines which are released by these activated cells. These cytokines, guys, which helps in the way, which has having a features of weight loss. Which cytokine is responsible? TNF alpha, which is having a fibrogenic cytokine or the wound healing activity property. TGF beta, which one is responsible for the granulomatous inflammation, guys? Interferons. And which helps in the attraction neutrophil? We have chemokines, alpha, beta, and gamma. Then the kinin system, guys, it activates the bradykinin, which helps in the fibrinolytic pathway, and this bradykinin is responsible for the increased permeability and pain. Then the complement pathway, these are the proteins which helps in the innate immunity, and if there is a deficiency of these complement proteins, we have autoimmune diseases. Most common complement protein deficiency, we have C2, but the function of this complement pathway in the inflammation, it has function of opsonization, chemoattractants, and cell lysis. Then the prolonged inflammatory process, guys, it will lead to the chronic inflammation. We have a modified macrophage, guys, a hallmark feature. Remember this. What is the hallmark feature, guys? Tissue damage or tissue destruction. The modified macrophage, we have Kupffer cells for the liver, littoral cells for the spleen, We have mesangial cells for the kidney, brain के लिए microglial, placenta is hopper, bone, osteoclast and lung dust cells. And these activated macrophages, guys, they will form epithelioid cell. Then along with the plasma, lymphocytes and macrophages, they will make a granuloma. In TB, guys, we have a caseating granuloma, sarcoidosis, non-caseating granuloma. Central necrosis, caseous necrosis present in the TB, whereas in the sarcoidosis, there is no caseous necrosis. There are less mononuclear cells. Then satellite granuloma, cat scratch disease, Donner granuloma, Q fever, Dirk granuloma, malaria, and gamma में syphilis. Then guys, giant cells, you already know Langhans giant cells seen in the TB, Ashkoff's in rheumatic heart disease, Ashkoff's may we have also caterpillar cells, okay. Reed Sternberg, we have oval eye appearance, Hodgkin lymphoma, even CMV is the same picture. Then Totten giant cell in the xanthoma. Then measles may we have Watson fecundly giant cell, asteroid body, sarcoidosis, Schwammen body is also sarcoidosis. Then the wound healing, guys, the collagen which helps in the scar formation is type 3. The hallmark of a wound healing is deposition of the granulation tissue. Remember, guys, abnormal wound healing, if it is outside the boundaries, it's keloid. Within the wound, guys, it is a hypertrophic scar. The most common location of a keloid is sternum. With the injection that we give directly to the keloid to decrease the growth, it is triamcinolone. We also go for the resection, guys, but its recurrence is common with. Is it okay, guys? So it was all about inflammation. So I hope, guys, cell injury and inflammation, guys, at least if 3 questions will come or 4 questions will come, but I have integrated it in a way at least 4 to 5 questions will come in with the integration. But if directly comes, guys, we can expect 2 questions, maximum 3 or either 1. But yes, guys, I hope, guys, the session was useful enough. If you have any doubts, anything to ask, guys, you guys can ping. You guys can just write in the comment section. I'm watching your comments. And tomorrow, guys, hopefully we'll have a last discussion, high discussion of an obstetrics and gynecology. Okay. Then further, guys, after 19, Meduhub is going to take the rapid revisions only, guys. So from 19 onwards, there will be only rapid revisions, no detailed discussions. Like this, we are going with a bit detailed discussion. There will be only rapid revisions now. Okay, rapid fire discussions, high discussions. Okay, so tomorrow hopefully we'll have a part 3 of obstetrics. Immunity, I'm not sure, guys, when I can take the immunity. So for now, tomorrow will be the last discussion of an obstetrics and gynecology. So make sure you join that. That will be very useful. Okay, so I hope, guys, inflammation and cell injury is done. At least you will be able to solve the question, because most of the times we directly go to the systemic patho. We don't. OB-GYN के 3 वीडियो enough हो गए FMG के लिए. I cannot say enough, but yes, if you have studied first your main notes, then my 3 videos will be more than enough, because I'm discussing around 30 topics. Okay, that is only useful. High rapid revision and high discussions are only useful when you have studied from a primary source first. If you directly jump over them, guys, you won't be able to understand. There should be basics. Okay. Yes, I will see if I will have time, and because from 19 we are starting rapid revision. Meduhub is planning the rapid revision, so we'll see accordingly. So make sure, guys, you join this rapid revision from all the faculties. Okay, it will be very useful for your preparation. Okay, guys, from 19 it will be starting. And already, guys, there are discussions on the Meduhub live channel, discussions over there. You guys can watch them in your free time. Jab bhi ho, once you are done with your primary notes, you please watch them. Okay, whatever source you are getting, just watch it. Chalo, guys, I hope we are done with cell injury and inflammation. So make sure, guys, you revise. Sir, for revision purpose, I'm asking. Yes, for revision, that is more than enough. I assure you. You go with the revisions, my 3 videos. Tomorrow will be the final one. You go with that, and that is more than enough. More than enough. I have a detailed explanation, the rapid revision, all the main topics I'm taking, all the main topics. Chalo, guys, I hope all the sessions, whether it's a PSM, OB-GYN or General Pathology, they're all useful from my side, and all the faculties are putting in immense efforts. So every one of you will pass the exam on 6th July. And if you have further doubts, guys, you guys can ping me on the Telegram, your doubts. And keep solving questions. Don't compare your knowledge with anyone. Keep going. Okay, keep studying. Focus on your notes. Don't compare your knowledge with anyone. And eventually, guys, you all will make it. Hai? All the best, everyone. Okay, good luck. Goodbye. Allah Hafiz.